So basically, the question I'm going to address is there a role for the osteoclast, which is traditionally a resorbing cell, in the way we think about bone formation and bone regeneration in some context. So the whole story started from a very simple angle. And as you all know, the osteoclast, it acidifies and it also secretes enzymes in order to resorb bone. One of these enzymes that is very critical is calypsin K, that is critical for the degradation of the extracellular matrix.
Yeah, my charge is to focus on soft tissue here and talk a little bit on tendon healing. So to start with, quite simply, the clinical problem, we know that tendon does not regenerate. Tendon heals by formation of scar tissue, and the structure, composition, and material properties of normal tendon are clearly not reestablished. Here's a normal tendon. Here's healing tendon, this hypercellular, disorganized collagen. Tendon attachment site is also critical. Here's a normal attachment site where tendon goes through this fibrocartilage transition zone, a highly specialized tissue with structure and composition, and clearly our healing models, we just have this disorganized fibrovascular scar tissue.
It's an honor to be here today to talk to you about my perspective on regenerative medicine as applied to articular cartilage. In the words of the renowned anatomist William Hunter, articular cartilage damage is a very troublesome disease. When destroyed, it is never fully recovered. Ever since these infamous words were penned in 1743, scientists and surgeons have tried to tackle this troublesome problem. But I think it is fair to say that with recent advances in engineering, surgical techniques, and in the biological sciences, we may finally have the tools at our fingertips to allow us to innovate in ways that until recently were unimaginable.
So I'll be focusing my talk today on the role of sonic hedgehog signaling, which we found to be important. So the intervertebral disc, I don't have to mention too much about it, but if you see the structure of intervertebral disc, it has mainly three components, and these are the three components or the two main important components that I'm trying to focus on. The outer layer of annulus fibrosus, these are fibrocartilaginous cells forming layers which engulf the nucleus pulposus, which is the gelatinous part of the intervertebral disc, and the end plate immediately adjacent to the vertebra.
So the concept in the lab is to develop a truly percutaneous injection delivered to the disc space, as shown in these two lower radiographs, basically a discography technique, which then begs the question, what would we need to inject in order to turn that disc into bone? So the first thing that came to mind were the bone morphogenetic proteins, the ones that are commercially available, BMP2, BMP7. These are growth and differentiation factors that are potentially able to take some of those cells from the disc or surrounding tissues and drive bone formation. And we naively thought in a lower level here that we'd be able to put those into the disc space and then turn that disc tissue into bone.
The cathepsin K. One of the clinical problems we have in joint replacement surgery is osteolysis. I'm sure you're familiar with it. And where bone is being resorbed around our implants, probably secondary to some kind of inflammatory reaction, stimulation of the osteoclast. And we have a lab here. We've been working on it for probably 10 years, trying to define the factors involved in that. Cathepsin K, I mean, is that something that you think could play a role, I mean, in terms of bone resorption in that environment?
Well, I'm certain it does, because the osteoclast cannot resorb efficiently in the absence of that enzyme. So, as you know, there are compounds that are in phase 3, that is almost completed, for osteoporosis, and they have shown so far in phase 2 really very efficient anti-resorptive activity.